Are you struggling to master neuro concept for the NCLEX or nursing school? Work with me. In this way, we have neuro patients that will teach you things you need to know for your NCLEX and nursing school in a straightforward way. Welcome to Neuro Crash Course. Are you ready? Walk with me with this neuro hallway. The first hallway, when you went to, there's a patient. What is the name? 67-year-old male. What is his problem? He's reporting about what? Drooping of the face, slurred speech, right arm weakness. What is the patient telling you? What should you worry about at this time based on what I've presented to you? Patient is telling you, act fast. And what is that? I have facial drooping, you should act fast. I have arm weakness, you should act fast. I have speech problem, you should act fast. And what is the problem? The T, time. What am I? My time limit, 4.5 hours. This is a stroke patient, and the patient has 4.45 hours in order to get life-saving information or medication. What action you should take? Don't send them to CT scan. What do? Make sure you assess their airway. Make sure they're breathing. Make sure their circulation is okay. Do what? A quick neuro assessment. Of course, you're going to put oxygen on them. And then you do a quick, not the full neuro assessment, checking their GCS and make sure where they are. And then you check their finger stick, right? For their glucose. Make sure this is not hypoglycemia. And then you can get your CT scan. You're going to activate the stroke team, and then you get a CT scan. This is the key. Why are we getting a CT scan? Because we want to distinguish whether this is ischemic versus what? Hemorrhagic stroke. If it is so, you get the TPA. What is ischemic stroke? No blood. That means there's a blockage. There's less blood going to the portion of the brain. What is hemorrhagic? Too much blood. That means either the vessel perforated and there's blood in the brain, intraparenchymal hemorrhage. We'll get a TPA. Number one, I told you, you should be less than 4.5 hours. You should not have any surgery within what? 2 weeks. That's the key. Within 2 weeks. After 2 weeks, you're safe. You should not have any brain surgery or brain injury within what? 3 months. Your blood pressure should not be uncontrolled. You should not have AVM malformation. You should not have aortic dissection. You should not be taking any anticoagulant depending on your INR or PTT. But this, if you know the 6 things I've listed, you know contraindication, indication for TPA. That's the key. And the patient has to be within 4.5. If you give the patient 4.5, if you give the patient medication within 4.5 is safer than after 4.5 hours. After you give them TPA, what should you monitor for? Changing mental status. That's the key. If you monitor them and they change, they get a CT scan. What kind of CT do they get? Non-contrast, not contrasted CT. It should be non-contrast CT. This is what you give to the patient. And this is the key. If we get the hemorrhagic stroke, what are we going to do? We're going to monitor your blood pressure. You're not going to have no TPA. And you're going to have surgery to evacuate the blood. Why this happen all of a sudden? That's the risk factors. Because your blood pressure may be too high, Mr. So-and-so. Because you may have hyperlipidemia, Mr. So-and-so. Or you may have peripheral vascular disease. That's the problem. They may have diabetes in a coronary artery risk, or may have AFib leading to embolic event. This is your room one. Thank you for saving this patient. You learn everything about, in the very short form, hemorrhagic and ischemic stroke. What is the signs and symptoms associated with it? What do you do when it comes to that? And the last thing, patient is asking for food. No, they cannot get any food. Why? Because aspiration risks. Therefore, they need to have what? Swallow steady before you can give them anything. Protect their airway, NPO, until they be evaluated by speech before you give them anything. Room one, you save this patient life. Are you happy? Well, they call you immediately. They say some 35-year-old female present in the next room with what? Acute onset of what? Slur speech. One side of the face is drooping and they are drooling. What do you think is going on? You assess the patient. There is no arm weakness. There is no leg weakness. You say, oh, why does this patient does not have arm and leg weakness? It's only the face and it's one side of the face. What do you think is going on with this patient? This is Bear palsy. You say, oh, I know this. This is associated with cranial nerve, what, 7. If it's associated with cranial nerve 7, then that side is affected. What is your treatment? You said this patient does not need TPA. Most of the time, it's more antiviral associated with viral infection, but they're going to need steroids. I got to do what? Teach them certain things so that they don't cause problems. So teaching will become my priority. What kind of teaching are you going to provide? Key, right? Oral care. Because of the drooling, no chewing or no food on the affected side. So put it on the other side. Take your medication. And then what? This is going to take about 6 months. Your face is going to take that long. And what is the thing? Your eyes. I got to protect your eyes, right? Because you won't be able to close your eyes. You won't be able to make some tears. So I give you artificial tears. That's the thing. You give them saline drops. That's the key, right? And then you have to provide some teaching to the eyes. During the day, I want you to wear what? Some glasses. At night, I want you to have a patch on to protect your eyes. Otherwise, you're going to have corneal injury. This is what you provide them. But this is going to take some time and it will go away. And the patient was said, oh, I thought I had stroke. Thank you very much. Room 2 saved. Well, you were high-fiving. Evidently, there's another patient in the same room, but on the other side of the curtain. He said his face. But what is his face? He said his face is throbbing, right? It's like shooting, pain. In the face, when I rub, it's like electric shock in my face. I can't even touch my face. Even if I chew or I brush my teeth, this is happening. What is going on? I don't have any facial drooping. I don't have slurred speech, but all I have is pain. And said, don't touch my pain. This is what? Trigeminal neuralgia. This is trigeminal neuralgia due to cranial nerve 5. Therefore, what would I do? Cranial nerve 5 problem. The treatment, same thing, medication, pain. And pain medication, this is why we call it multimodal. That means you give them anything you can think of. They get NSAID, they get Tylenol, acetaminophen, they get what? Antidepressant, SSRI, they get TCA, they get anything, they get opioid that you can think of, right? Like maybe morphine, but the normal one is what? This is you have to know for your NCLEX. It's anti-epileptic, and that is what? Carbamazepine. And this is the normal one. What do you teach them infection risks because it causes agranulocytosis. And the patient said, oh, that's fine. But you said, no, that's not fine. I got to make sure you don't come back. Therefore, do not rub your face. Chew on the unaffected side. When you brush your teeth, just use your what? Bristol toothbrush. Otherwise, you're going to come back with the same thing. But take your medication, and when you're drinking, make sure you don't drink anything that has extreme temperature, something that is too cold and that is too warm. They say, oh, I have trigeminal neuralgia, pain problem. It's better than my neighbor who is drooling. I'm not drooling. And that patient is happy. You save those two patients in the same room. And they said, okay, next time I know what to do. Are you ready? The bell rang, and the room 3, they call you as usual. And you said, well, the stroke patient that you deal with there's another patient who already had stroke. What is this problem? He had head injury due to stroke. So post head injury. And then he's been being monitored. All of a sudden, he's vomiting. What is it going on? His blood pressure is 180 over what? 100. And his heart rate is 45. What is that patient telling you in that room? Remember, he had stroke due to hemorrhage, head injury. Now he's vomiting. The blood pressure is 180 over 10 and a heart rate of 45. This is what we call what? Cushing triad. Patient is telling you he's going to herniate. You have hypertension, blood pressure problem. You have bradycardia. You see, and then they're vomiting. Then when you did the assessment, he has irregular respiration. This is what we call Cushing triad. What is your priority? Immediately, don't call the doctor. Elevate the head of the bed to like greater than 30. You will save this individual. It's about to what? Herniate. If the patient is intubated, blow them, hyperventilate them. This patient is not intubated, but if the patient is intubated, you're going to hyperventilate them to blow out the CO2. Hypo what? Make sure the CO2 is low to like 30, and that will help the individual. When you call the doctor, you know what to expect. What do you expect? You're going to look for osmotic diuresis, right? That is the medication you're looking for. And what is that? Mannitol. You're looking for mannitol. Oh, you said, well, if there's no osmotic diuresis, I'm going to ask for 3% normal saline in order to decrease the ICP. These are the key. No hypotonic fluid in this patient, but this is what I need to do. If I'm giving you mannitol, what should I worry about? My priority is pulmonary edema. This is your key. I'm just giving you concept that the NCLEX will ask you. I don't want to give you a long lecture, but if you're struggling, these little things, if you know about post-head injury, is enough. Of course, there's more videos you can watch. I have more videos in if you want details, but those videos, the little things I want you to pick from it, is what I'm giving you on the post-head injury patient. So don't forget the situation. Don't forget these signs and symptoms. You finished this room and you said, oh, I've conquered 4 rooms already. Now, the nurse said, don't go because you are the only person we got. So keep on going to each room and fix them. Room 4, what is it? It was a child in that room. The bed is shaking, right? And then his eyes is rolled back. His tongue, you can see he's trying to bite the tongue. What do you think is going on with this patient? This patient is having seizures. What will you do? Airway. Protect the airway and prevent injury as much as possible. So what do? Place the patient on the left side. and some small pillow below the head, under the head. And the UAP is standing there. He said, let's restrain the patient. And you said, no restraint. But what did you tell them? Remove all constrictive clothes as much as possible. He said, oh, that's what I'm supposed to do? Okay. He said, then the UAP said again, let's put a tongue depressor or bite tongue in the mouth in order to prevent them from aspiration. You said, no, nothing in the tongue or in the mouth. So you said, why? She said, what? You said, well, that's going to cause too much problem. Don't put anything in their mouth, nothing like that. And then the UAP said, let's give them oral medication, anticonvulsant, anti-epileptic. You said, no, because they're seizing, seizure, acute seizure, they need what? Benzodiazepine. Active seizure need benzodiazepine, no anticonvulsant. And you said, oh, okay. She says, okay, I learned something here. If you're an active seizure, the most important thing is what? Airway, breathing, circulation, protect the head, and then prepare to give anticonvulsant. After the stroke, after the seizure, what should I do? Protect the airway, protect the airway, and then reorient the patient. And that's what you did in room 4. And you saved this patient from seizures. The next patient in the same room, waiting, what? In the same room for, what is the difference? That patient is not falling down. You're talking to the patient came, it was observing what was going on. Then all of a sudden, he has a blank stare, right? Blank stare. He's looking at the sky. He stopped talking. In the 3 seconds, oh, he come back. And he does that again multiple times, but he did not fall. He did not do anything. What do you think is going on with this kid? He's a 3-year-old kid in the same room. Blank stare, and he be blinking his eyes, and he doesn't know where he is. Then he come back again. But no falling, no loss of consciousness or nothing like that. This is what we call absent seizure. So remember, absent seizure is different from regular tonic chronic seizure. You are not going to absent seizure. You are not going to fall down, and you're not going to have any loss of consciousness that's associated with falling down, biting your tongue, anything like that. You just have a blank stare. And the nurse said, good job. The UAP said, good job. You saved this patient. Thank you very much. But then you walk to the next room, your room 5 is dangerous. Patient is complaining about headache. He says stiff neck. He's a college student. And he said, I can see, he burned to see photophobia. Oh, what is good? And I have a fever, 103. The kid is in droplet precaution. He said, oh, I know this one. This is what? Meningitis. Probably did not get immunization. Then you did more assessment. You said, what? Fever? Nocturnal rigidity? I know this. I got to get more assessment to make sure this is right. And then what do? You burn the neck, and the kid starts screaming. That's Brudzinski, right? The neck, burning of the neck is Brudzinski. That's what you say. You told the UAP that. You said, well, how about the knee? Let me extend the knee. So I extend the knee, and then we have pain also inside. So those are all I know. I said, I confirm that this is 100% meningitis. And we're going to maintain our what? Droplet precaution. What we wear for droplet precaution? What? That's a surgical mask. That's all. We don't need to wear anything. No N95, no gown, gloves, just surgical mask. Now, what do we do? What do we do? We got to confirm it with the laboratory. What do you think this patient is going to have? They're going to do lumbar puncture using so that we can get cerebrospinal fluid. And this lumbar puncture, you have to know how to take care of this patient, right? They're going to be on their lateral side, like in the fetal position. After the procedure, you put them in their what? Supine position so that they can apply pressure. Before, on their side, after the procedure, supine position. What is the common side effect? Headache. I'm giving you content that is straightforward, and I want you to stop the video every time, write this little thing. This is all you need for meningitis. Of course, you need some coaches and everything, but this is little, even if they give you a case study, what do you do? What is the expectation from the nurse? IV antibiotic. We're going to continue with what? Our droplet precaution, infectious control. And then we're going to monitor for ICP, because if the ICP goes up, we have problem. If the ICP goes up, once again, we have problem. This is the key. In the last thing, if this is, you think this is a bacteria meningitis, when you look for the CSF, cerebrospinal fluid, you're looking for neutrophils. If it's a viral problem, you're looking for lymphocytes, in case they give you in that case. But I'm just giving you little things so that you will be confident. When you see questions, you know I'm looking for signs and symptoms about meningitis. It's on the board. What kind of precaution is on the board? What kind of signs and symptoms regarding Brudzinski and Kernig is on the board? And then what should I monitor for is on the screen. What do I need for lumbar puncture? Right there. And how do I place the patient? That. What is an expected finding? Headache. How do you prevent it? Fluid. This is adapting class. You're walking through the neuro ward. You've taken care of 5 patients. You went to 5 rooms. You've saved them. They all have problems that nobody can fix because you master your content. And you said, I know this. Now, in room 6, what is the problem? This is a 23-year-old. He's a footballer. He played football. He had injury, brought in, and now he has flaccid paralysis. And he's below T6. What do you think should be your priority? Well, you know he has a spinal cord injury. That's classic. This kid is what? He has problem with moving the leg. Depending on the location of the spinal cord, you can have different kind of mobility. If it involves the cervical, this is going to be completely quadriplegic. If it's in a thoracic area or lumbar area, mostly it's going to be what? Paraplegic. So for this patient, it's a paraplegia. I'm just using this to teach you how you can distinguish between them. Our patient, he has flaccid paralysis below what? T6. So flaccid paralysis below T6, this is going to be what? Paraplegia. And when you walk in, what do you see? Patient is diaphoretic. He's complaining about headache. He's restless. Right. And his blood pressure is high. What do you think? He has T6, flaccid paralysis below TC. What do you think is going on with this patient? How does this give you a knowledge on this prevalent spinal cord injury patient who is young, TC is below, and then you see diaphoresis, headache, restlessness, and hypertension? You know that this patient is having what? Autonomic dysreflexia. So you know what to do. What do you want to do? Number 1 thing, head of the bed, upright. Okay, elevated. And then what? Remove all triggers. What are the places you got to look? A, check into their bladder. If there's distended, put the Foley in. If the rectum has stool there, disimpact. And then if they have constricted clothing, remove them. right? And these maneuver alone will decrease their ICP. All these signs and symptoms that I'm describing, headache, diaphoresis, restlessness, hypertension, is ICP. Therefore, autonomic dysreflection is an ICP issue. So what do you teach the patient? So what do? You do things to decrease ICP like we saw in this first patient. And then you talk to the doctor. If their blood pressure continue to be high, then they need medication. But most of the time, medication is not needed. So you have to keep on checking the blood pressure. If it doesn't respond with what we have, then you know they will need medication. Room 6 down. Are you taking care of a bunch of patients? Are you happy? I'm happy for you because we are walking through the neuro ward. And then you went to room 7. You walk to the room 7, patient is trying to walk. He's walking, but what is he doing? He's shuffling his gait. He has P rolling. Tremor. Some of this tremor is at rest. And he moves slowly, slow movement. He has changed his center of gravity because he's afraid of falling down. What do you think is going on? I'm giving you signs and symptoms. The new test plan that comes out, there's something they call what? They're not going to give you a bunch of information. They'll give you a little bit, and you got to figure out what is wrong. This information is enough. Shuffling gait, rolling tremor, resting tremor, slow movement is a classic symptoms. You don't expect them to give you all the signs and symptoms the patient is going to have. This is what we call Parkinson's disease. And then what do you want to do? Since you know this is Parkinson's disease, you investigate and you find out more that what is going on with the patient. You say, oh, tremor, I know it. And you see that the patient is very rigid. And when he want to move, it takes him a long time to start. So he has akinesia. Hey, what is going on? I know this. Or bradykinesia. And you see his body is not in the right place. Postural instability. That's why he's trying to shuffle his gait so that it doesn't fall and he stoop forward. This is what we call trap. Patient is being trapped in his body and he has Parkinson's disease. How do you help with this trap? You know it. You know it. You say, what? I know this is due to what? Substantia nigra. There's a portion of the brain that control our movement and is being affected. Now, the individual, usually dopamine is what helps us to control our movement. We can initiate it. These guys, substantia nigra, dopamine is down. And what is the problem? He has too much acetylcholine. Elevated acetylcholine make him move when he does not want to move. That's all. And this is your pathophysiology. He said, well, I know what to do then. If there is no dopamine and there's too much acetylcholine, I'll block acetylcholine and give them more dopamine. How do you give them? They say, well, let's give them levodopa. Well, levodopa get broken down in your stomach. And you say, well, fine, I'll combine it with what? Carbidopa. And carbidopa, levodopa is what you give this patient. The carbidopa is a carrier, is a bus, is taking levodopa to the brain to do its function. What other medication you can give them? Block acetylcholine. Anything that you can think of that is an anticholinergic. I'm not going to give you a bunch of list, but if you see your question and you see that is anticholinergic, it's good for what? This problem. Have you heard about benztropine? Cogentin, that's it. This is cogentin. When you see cogentin, it's anticholinergic. It's used in Parkinson's disease to help block acetylcholine. And then levodopa, carbidopa is for what? They are dopamine. Of course, there is certain things you have to teach them about this medication. Levodopa, carbidopa, your urine can change color, orange, yellow. It's fine. They're going to have orthostatic hypotension. It's fine. But number one is when they start having tardive dyskinesia. Remember, too much dopamine will also make you move. So if they have lip smacking, hey, I got to stop it. So tardive TD, right? Tardive dyskinesia. First, they cannot move. Now you give them too much dopamine, they can move answers. We call it tardive dyskinesia. I got to stop. Lips marking, all those things are bad side effects of carbidopa, levodopa. And Claes is going to ask you, you master it, and I know you know it. Remember, this patient is going to fall, and we want to prevent fall as much as possible. So you conquer room 7, and you said, I'm going to room 8. I'm ready for you. I'm on the roll. On the roll, room 8 is dangerous. Why? It's not easy to diagnose. What did the patient tell you? Blurred vision. Okay, what is the problem? You said, I'm tired. I have some depression. I have weakness, numbness everywhere. And this being like happening alternative side. So one side is on the left, and then 6 months later it's on the right, like 6 months span. It keep on coming. And then all of a sudden, the whole will be gone. You see what I told you? Alternative signs and symptoms, multiple neurological symptoms all over the place. They have vision problem, depression, weakness, numbness, but this keep on coming. You cannot pinpoint if whatever is the problem. But because it changed in time and space, it just happened, then it goes away all of a sudden, you know, that's your clue. It's because of time. I'm using time to make a diagnosis. What do you think is the problem? I want you to stop the video, put that answer in the comment. Tell me what you think this room 8 symptoms is before I give you the answer. Multiple neurological symptoms in different space and time is what? This is multiple sclerosis. That's why it's multiple, because it's affecting multiple portions of the brain. It's an autoimmune problem, and it's a degenerative issue. Oh, that means I'm losing it. I'm not going to get it back, right? And I'm going to have a bunch of problems. Your management is steroid, immunosuppression, because it's what? Autoimmune disease. Then I got to manage all the signs and symptoms the patient is talking about. Fatigue. You got to manage. You got to manage about their bladder issue, right? You got to manage about stress and triggers. Triggers, especially what? Vaccination. I want you to get your vaccination. You're going to have an inability to sense hot water and other things. So just watch for heat stress. Very, very important. Otherwise, you're going to burn yourself. And then if I give you what? Medication for this, I need to pay attention, right? If I give you medication about your immunosuppression, it depends on what I give you. If I give you what? Hydroxychloroquine, what are you going to tell the patient to check? Well, they got to check for vision problem. They're going to have retinal issue, right? Those are the things. They're going to lose their eye, so they got to see the doctor for hydroxychloroquine. Ophthalmology, very important. If you give them methotrexate, they have to know they can be pregnant. So there's so many pharmacology associated with what? Management of multiple sclerosis, depending on what you give them. But the priority is safety and teaching associated with it. That's the key. Room 9 is down. Then you move to the next room. You said, well, I'm on a roll. Let me just take care of this patient. But this patient, you went to the room this story did not make sense. He said, I wake up last night, my leg is weak. And where does it start? It starts from my toes, then went to my ankles, then it went to the knees, then to my hips, now my hands, everywhere is weak. It looked like it's ascending on me, even though I have not done anything. And then you probe, you say, well, what happened? You say, oh, we have diarrhea 2 weeks ago. I was fine. We went on camping trip as diarrhea. But after 2 weeks, then this happened. You say, oh, I know you have Guillain Barré syndrome. So what do you mean? Who is Barré syndrome? I don't know who is Barré syndrome. Say, yeah, you have autoimmune disease due to the bacteria infection that you had when you have diarrhea. Now, this bacteria is affecting your nerves. Luckily, it will go away. It can take like 6 months. Your body is fighting the bacteria, but this bacteria is also affecting your what? Your nerves, and this is affecting your muscles. That's why you're having ascending paralysis. And my number one thing is to keep you alive is your airway. So we got to make sure your muscles in your airway are all intact. And so that's what we're going to do. You may need ventilator. You may have to do tracheostomy. You may need a feeding tube because you may not be able to swallow. So those are the things. Right now, what we're going to do is going to take your blood out. We're going to do something we call plasma pheresis. Wash all your blood and make sure we remove the antibodies, and then we can give you antibodies, IVIG. That's the management for this problem. But it's going to be supportive care. What is my priority? If your voice change, I'm worried about it. If you have dysarthria, I'm worried about you because that's an airway. So I'm going to monitor you and make sure this does not happen. That is your room 8 and 9. And you say, oh, this one is dangerous. I thought I'm going to lose that one, but he's happy. Then you went to the next room. What do you see? This guy, he fell. He was hit in the head during a soccer game, and he fell down. He has a brief loss of consciousness. But right now, it's fine, except he has headache and he's been vomiting. So he has a head injury, as you can see. And so what do you want to do? You want to make sure this is TBI on concussion. That's the key. That's the problem. But when you get a CT scan, there is no blood. So because there's no blood and there's no injury to the brain, this is what we call concussion. So what are we going to do? Mostly monitoring this patient, making sure everything is okay until they're ready to go home. But the other one, a few hours later, you get a CT scan. Hey, there's blood in there. And that's what we call intraparenchymal hemorrhage, TBI. This patient is in trouble. You have to monitor their GCS, and you got to calculate their GCS. How do you know whether this is severe or not? If it's less than 8, that's a problem. And if it's less than 8 severe, we're going to intubate you. Therefore, these are the things you have to monitor for. Monitor ICP in this patient. What do? Raise out of the head of the bed. No suctioning. Keep the head midline. Okay. Don't let them burn. All these things is how to manage ICP. Frequent neuro check. I know you know it. I'm going to repeat it again because the key, right? If he's intubated, no excessive suctioning. Okay. Keep the head midline. Okay. Don't keep on rotating it. Neutral position as much as possible. Don't suction them, right? They may need antiemetic, okay, to prevent them from coughing, and keep the head of the head 30 degrees as much as possible. This is how you manage the ICP in this patient. Since it's intubated, make sure their CO2 is not greater than 35 or 30. That's your key. You see, you know how to manage a patient with a TBI and ICP. And then you say, oh, all these rooms are teaching me something. But I see that we have a bunch of staff. Every patient, I got to give them some medication. So I got to know a little bit more. You took your encyclopedia, you said, okay, this is med, let me look at it. You say, I learned about levodopa, carbidopa. I know it's used for Parkinson. I know it's the side effect associated with it. So orthostatic hypertension, checking your urine, severe side effect is tardive dyskinesia and all those things, right? I said, well, I know somebody has seizure, right? So what do I use? I give them anti-seizure medication. Oh, okay. I need to know some few stuff about them. And we talk about what? What do we talk about? You say, hey, yeah, we did not give them anticonvulsant, but we give them benzo. But I need to know a few. They said there's something called phenytoin. What do I need to know about phenytoin? No protein, right? It hate protein. Therefore, if I'm giving to the patient, I should stop the protein. These are all sulfur drugs, so they can cause problem associated with sulfur. If you're on phenytoin, you can have what? Gingival hyperplasia, right? All these things I need to know about so that when I see it in the patient, I can teach them about signs and symptoms associated with this. These are little pharmacology I need to know about it. And they said, okay, by all means, you know something about it. He said, okay, what else do I need to know? Valproic acid. What is valproic acid? The number one thing you call pancreatitis. That's also very bad that I need to know if the patient start complaining of abdominal pain, I should worry about it. We talk about carbamazepine. And what is the problem? Because it's agranulocytosis. So we got to teach them about infection risks. And they said, hey, remember the kid with the absence seizure? What do we give the patient? He said, oh, ethosuximide. That's what you give it to the patient. It's also a sulfur drug and should pay attention about it. So, oh, I've learned some pharmacology and I'm learning a lot. Then on your way, leaving the ward, they called you. They said there's 3 patients left to be seen. They are not that difficult, but you need to see them. So you went to the other room, and what do you say? This guy is slowly losing his leg. And he's getting weaker and weaker and weaker each day. And he's tripping. And they told you this is progressive. It's due to motor neuron disease as you read the chart. And he's going to be weak and he have atrophy. Is he intubated? He has gastrostomy for feeding. And they told you there's nothing they can do about this patient. But he's going to die in 6 months. He has respiratory failure. He has cognitive function that is intact, but most of the things is going on, it cannot function properly. What do you think? There is no ascending paralysis. This is what we call amyotrophic lateral sclerosis. So that's this patient. It's different from Guillain Barré syndrome. That's this patient. It's different from Guillain Barré syndrome. So this is what ALS. That's that patient. The next room, the next neighbor in the same room is older lady, 70-year-old female. And what is it? She's confused. And she's forgetful. She does not recall the name of her grandchildren, does not remember them. But she cannot remember the name of the grandchildren. And slightly agitated. What do you think? What do you think? You remember, and you said, oh, memory loss, confusion, impaired judgment in this patient. This patient has Alzheimer's disease. And so what priority should I have to worry about is safety. Reorient this patient as much as possible. And then we expect some prescription for them so that we can use to treat them. What is the problem? Donepezil. That's the easy one you can remember if you don't remember. And anything else associated with this problem is like myasthenia gravis patient. You give them rivastigmine to improve their acetylcholine. That's what is causing their problem, and that's why they have this condition. And luckily, his next door neighbor, the third person in the room, is like 35 years old. And what he's complaining about? He says he's drooping eyes. He can't see well. Vision problem. Then he says swallowing problem. And this girl was drawing worse at the end of the day. They say, oh, what is going on? Drooping of your eyes, swallowing problem, and it get worse during the evening. But during the day, you strong in the morning. You say, I know this. This is an autoimmune problem. It's because you're fighting against your acetylcholine. You're killing yourself. That's why you fatigue. And then during the end of the day, it get worse and worse and worse. Therefore, what we're going to give you is like what we give the Alzheimer's patient, but different type. We're going to be neostigmine. Right? They do the same thing, improve your acetylcholine. But I got to worry about something. I got to worry about something. If I give you neostigmine, there's two things that can happen. I can give you too much, and you have too much acetylcholine. If you have too much acetylcholine, you're going to go cholinergic crisis. Versus you have myasthenia gravis crisis. What is the difference? Acetylcholine. Cholinergic crisis means I give you too much acetylcholine. Therefore, what is going to happen? Excessive acetylcholine, you're going to have urine output will increase. You're going to have what? Diarrhea. You're going to get hot. You have salivation. You'll be drooling. That's a bad problem. But what is myasthenia gravis crisis? It means you don't have acetylcholine. That's an airway problem. Everything starts going down. You're getting weak. So know the difference between these two conditions. Know the difference. Cholinergic crisis, myasthenia crisis means myasthenia gravis crisis means they're weak and weak and weak. Cholinergic crisis means I give you neostigmine and it become SS. What do you give them when they have cholinergic crisis is atropine to stop everything. What you give them when they have myasthenia gravis crisis, acetylcholine, you give them neostigmine. That is the difference between those two information. And as you can see, you walk through all of the neuro ward. You've seen a bunch of patients, multiple problems. You run it through a stroke patient, ICP issue, patient who have seizures, patient who have meningitis, patient who have spinal cord injury, Parkinson, myasthenia gravis, GBS, multiple sclerosis, ALS, TBI, neurocheck, everything, Parkinson, Alzheimer's that the NCLEX want you to know, including some few pharmacology. This was not designed to give you every little details, but to give you something to hold on to as a scaffold to use to answer question. If you need more, check out that NCLEX detailed information, but all the things you need to answer questions is in this video. Thank you for saving all this patient life. Thank you for watching, and good luck in nursing school and adapting class. Like the fact that you stick around. And if you like this video, put a comment and say, I'm Master Neuro Concept for nursing school and NCLEX. Thank you, and subscribe for more content like that. Take care of yourself. Bye.